Let us start with symptoms of cardiology. The left side of the heart is related to the lungs, so we have pulmonary congestion in left atrium failure, and that's manifested by dyspnea, which is the first symptom in mitral stenosis, which leads later to left ventricular failure. Pulmonary congestion related to systemic venous congestion in the right side of the heart is related to the systemic circulation, so we have systemic venous congestion in right atrium failure that is manifested by edema due to right ventricular failure. Low cardiac output occurs first in aortic stenosis and is manifested by syncope. Low cardiac output is related to cyanosis. Cyanosis, age and differential diagnosis. Age of onset, since birth in Fallot's tetralogy. Few years after birth in Fallot's trilogy. In teenager in Eisenmenger's syndrome, reversed shunt. Above age of 40 years in COPD with or without cor pulmonale. Differential cyanosis, PDA with reversed shunt. Cyanotic spells and squatting, Fallot's tetralogy. Exertional cyanosis, cases of cardiac shunts, cases of a cyanotic Fallot's, interstitial pulmonary fibrosis. Pain, it's the main symptom. Discussed later. Palpitations due to arrhythmia, discussed later. Pressure manifestations. The most posterior chamber of the heart is the left atrium, which is markedly enlarged in mitral stenosis and mitral regurg, causing pressure symptom on trachea, brassy cough, bronchus, dyspnea, esophagus, dysphagia. Left recurrent laryngeal nerve, hoarseness of voice, aortnas. Superior vena cava, edema and cyanosis of face and upper limb. Blood pressure changes, discussed later. Fever. Causes of fever in cardiology could be 1. Cardiac. Endocardium, infective endocarditis, that's a serious. Rheumatic fever, is the commonest, myocardium. Myocarditis, myocardial infarction, pericardium. Pericarditis, effusion. 2 vessels, thrombophlebitis. DVT3 lung, pulmonary embolism, pulmonary infection. Thromboembolic manifestations. The embolus is insoluble material in circulation. Its source could be left atrium in mitral stenosis and atrial fibrillation. Valve, vegetation in infective endocarditis. Ventricle, myocardial infarction. Vessel, aortic atheromatous plaque. The embolus can move to cerebrum causing hemiplegia, coronary artery causing chest pain, peripheral artery causing pulseless, pallor, paresthesia or paralysis, eye causing blindness, renal artery causing painless hematuria, superior mesenteric artery causing intestinal obstruction, and abdominal pain. The history, common presenting symptoms, 1. Pain. 2 main types, intermittent and acute. Remember that anginal pain never to be localized. Inframammary. Stitching. More than 30 minutes. 2. Dyspnea. 3. Palpitations. 4. Syncope and presyncope. 5. Edema. 6. Blood pressure changes. And 7 others. 1. Intermittent pain. Cause. Intermittent myocardial ischemia, angina pectoris. Unstable angina caused by chronic narrowing in one or more coronary arteries. Typically, a dull discomfort, often described as a tight or pressing, band-like, sensation akin to a heavy weight. Site, across the anterior chest, retrosternal, radiation, down one or both arms, left shoulder, and into the throat, jaw or teeth. Increased, exercise, sexual intercourse, stress and heavy meal, heavy smoking, hypothermia, high attitude. Decreased, rest and or sublingual glycerol nitrate spray. Duration, less than 10 minutes. Maximum 10 to 30 minutes. Associations, anger or anomie, which is fear of death, dyspnea and sweating. The degree of physical exertion required to precipitate symptoms is a better guide to disease severity than the intensity of discomfort. This table shows classification of stable angina according to Canadian Cardiovascular Society. Grade 1, ordinary physical activity does not cause angina. Grade 2, slight limitation of ordinary activity. Grade 3, marked limitation of ordinary physical activity. Grade 4, inability to carry on any physical activity without discomfort. It may be difficult to distinguish between angina and non-cardiac causes of episodic chest pain, such as esophageal pain or musculoskeletal problems. The latter may occur at any site over the chest, often vary with posture or specific movements, twisting or turning, and may be associated with tenderness to palpation. Ask about site, onset, severity and character of the pain, and whether the pain radiates anywhere. Associated symptoms such as breathlessness, aggravating and relieving factors, especially their relationship to exertion frequency and duration of symptoms, and any recent change in pattern degree of limitation caused by symptoms. To differentiate between cardiovascular causes of chest pain, the following table would be helpful. Esophageal pain can be epigastric, the others are retrosternal. Anginal pain progressive, myocardial infarction rapid, aortic dissection very sudden, pericardial pain gradual, esophageal pain sudden. Angina and myocardial infarction heavy in character, aortic dissection tearing, pericardial pain sharp stabbing, esophageal pain burning. Angina, myocardial infarction radiate to arms, neck and epigastrium, the others to the back. You can differentiate myocardial infarction from angina by sweating, nausea, vomiting and anger or anemia. Aortic dissection characterized by syncope, limb and mesenteric ischemia. Pericardial pain flu-like symptoms and fever. Esophageal pain heartburn. Anginal pain is intermittent 2 to 10 minutes. Myocardial infarction prolonged 10 to 30 minutes. Aortic dissection prolonged. Pericardial pain variable. Esophageal pain at night time. Both angina, myocardial infarction increased by exercise, angina relieved by rest and nitrate, myocardial infarction not. Aortic dissection no maneuver relieve pain. Pericardial pain sitting or lying down may affect intensity of pain, NSAIDs help. Lying flat, some foods increase esophageal pain and not relieved by rest. Angina mild to moderate, myocardial infarction severe, aortic dissection very severe, pericardial pain can be severe, esophageal pain usually mild, but esophageal spasm can cause myocardial infarction. The cause of angina is narrowing due to coronary atherosclerosis, aortic stenosis and hypertrophic cardiomyopathy. The cause of myocardial infarction is thrombosis due to plaque rupture and coronary artery occlusion. Pericarditis usually viral or post-myocardial infarction. Esophageal pain follows esophageal spasm, reflux and hiatus hernia. Acute chest pain. 1. Myocardial infarction. Symptoms are similar, but more severe and prolonged than those of angina pectoris. Associated features include restlessness, breathlessness and a feeling of impending death, anger or anemia. Autonomic stimulation may result in sweating, pallor, nausea and vomiting. 2. Pericardial pain is typically a constant anterior central chest pain that may radiate to the shoulders. It tends to be sharp or stabbing in character, exacerbated by inspiration or lying down, and relieved by sitting forwards. It is caused by inflammation of the pericardium secondary to viral infection, connective tissue disease or myocardial infarction, or after surgery, catheter ablation or radiotherapy. 3. Aortic dissection. A tear in the intima of the aorta is usually associated with abrupt onset of very severe, tearing chest pain that can radiate to the back, typically the interscapular region, and may be associated with profound autonomic stimulation. If the tear involves the cranial or upper limb arteries, there may be associated syncope, stroke or upper limb pulse asymmetry. Predisposing factors include hypertension and connective tissue disorders, such as Marfan syndrome. As with intermittent chest pain, explore the characteristics of the pain, and ask specifically about associated symptoms that may guide you to a likely diagnosis, such as interscapular pain, sweating, nausea, vomiting, syncope or neurological features.